Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our symposium series. I also want to take this opportunity to thank all of you who become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
Good afternoon. My name is Maxim Itkin. I'm an interventional radiologist from University of Pennsylvania and Children's Hospital of Philadelphia. My expertise in medicine and interventional world and radiology is lymphatic imaging and interventions. So we'll start with lymphatic system function. And there was a genius over 100 years ago, Dr. Aaron Starling, who understood how lymphatic system works, how lymph is generated. And he came with this concept that the lymph is generated based on a balance of hydrostatic and oncotic pressure. And the main function of a lymphatic system, besides immune, is to remove the residual fluid and proteins from the tissue, soft tissue, and deliver it back into the venous circulation. Lymphatic system is very complex. It has multiple subsystems. The most important of them are peripheral, soft tissue, liver, and intestine. And specifically, liver and intestine lymphatic systems are overlooked over the last 60, 70 years. Why they're so important? Because they generate approximately 80-90% of the flow in the body, lymphatic flow in the body. Why lymphatic anatomy is very complex? Because lymphatic system is developed through multiple primordial buds that fuse together. And that's one of the classification of the central lymphatic system of the thoracic duct. And you can see here that even two most common variants of the lymphatic system accounts only for 40% of the anatomical variant. So this is a slide of lymphangiogram where we inject dye into the thoracic duct. Both of them are normal. On the left, there's a normal thoracic duct, single one, how it's supposed to be in a medical book. On the right, there are multiple collateral vessels. Why we think that on the right is normal? Because this woman is 84-year-old and she has been completely asymptomatic until a surgery, lung resection, caused the rupture of his lymphatic ducts. Why the lymphatic system is so elusive? Because it's very, very difficult to image. These two techniques, pedal lymphangiogram and pedal lymphangiography, were the only imaging techniques we ever had until recently. Both of them technically challenging and provide minimal information about central lymphatic system. A few years ago, we developed this technique that we call intranodal lymphangiogram as a substitute for the pedal lymphangiogram, where you can inject contrast material into lymph node in the groin using ultrasound guidance. That's how it looks like. It takes 5 minutes to put a needle inside the lymph node, and everybody who knows how to hold ultrasound probe and do intervention, any interventionist can do that. And that's the reason why all lymphatic interventions, there was an explosion of the lymphatic interventions literature and procedures over the last 5-6 years. That's how it looks on the patient. On the left, you can see lymphangiogram here, and this is two needles in the groins of the patient. We can also inject, instead of lapidol oily contrast, gadolinium. Gadolinium, it's an MR contrast and that potentially we can see the lymphatic system. So here, fortunately, we can do it because the new MR machine come with detachable tables, so you can put needle into lymph nodes outside the MRI machine. Right now, we confirm the position of the needle into lymph nodes using this ultrasound contrast. You can see here, this is a lymphatic ducts in the groin. And then we can get pictures similar to that. This is normal. This is over 10 minutes. Beautiful, normal thoracic duct. But here's something clearly abnormal. Here you can see that there is a abnormal lymphatic flow from a thoracic duct go inside the lung parenchyma on MRI. And when we inject thoracic duct, we confirm the same findings. This is a patient with idiopathic chylothorax. When you have a new imaging technique, such as MR lymphangiography, you can find new diseases in new findings. And that's what happened to us. We found our first patients what we started to do MR lymphangiogram condition that we now call pulmonary lymphatic perfusion syndrome. It's an anatomical variant. On the left, you can see the list of all different diseases, not complete, that actually have this anatomical substrate as a disease process. So what is that? Here you can see the thoracic duct takes all this lymph from the lung and delivers into the and this lymph from the lung delivers toward thoracic duct, whereas in pulmonary lymphatic perfusion there's opposite flow. The lymph from the thoracic duct flows into the lung parenchyma. Sometimes this part because of absence of this part of the thoracic duct, but not often. This is just a schematic representation of the same situation. Lymph, instead of going thoracic duct all the way up, end up into the bronchi. This is how it looks on MRI. On the left, it's normal. On the right, it's pulmonary lymphatic perfusion. In this case, it's a kid with plastic bronchitis. And this is the first condition we discovered having this pulmonary lymphatic perfusion syndrome. Plastic bronchitis. Plastic bronchitis, this is a rare condition where the kids or adults formate large casts of their airway and cough them out. It's very relatively common disease in congenital heart disease patient, but we also see it quite a lot right now in adults. So this is an MRI of patient with plastic bronchitis. You can see the contrast, instead of going all the way up in the thoracic duct, actually goes into the lung, into the hilum of the lung. This is MRI and this is injection of the thoracic duct. What can we do about that? We can actually close this lymphatic pathway doing a treatment that's called thoracic duct embolization that we employ quite often for treatment of chylothorax. So usually we start with Lymphangiography to understand the anatomy, and then we can see the origin of the thoracic duct that supplies this bronchial tree. And we can see it here. We can take small needle, stick the thoracic duct, put a wire, and then we can inject the dye, catheter, and then we inject the dye. And you can see there's abnormal perfusion go toward the lung parenchyma in this patient with plastic bronchitis. If we inject blue dye while we're doing bronchoscopy, we can actually see how this submucosal bronchi are perfused. And a few 20 minutes later, you can see this creation of the cast of the lung. What can we do about that? We can glue it. You can see on the left, this is injection of the glue in the thoracic duct. Glue is already opaque. We actually can see it under X-ray. And that's an excellent treatment. We recently published a paper about first 20 patients in circulation, and then by now we probably did over 100 patients. So the same condition exists in adult patients without obvious heart disease. This is a patient that presented with 5 years of scoring cough. You can see again there's abnormal flow going in the lung parenchyma. Again, we can put a catheter inside and we can inject contrast and embolization material and close that. This is our article from Annals of American Thoracic Society with first 7 patients. Right now we did close to 30, and we actually can achieve complete cure of this patient by closing the flow in the thoracic duct. Always question, if you close the flow in the thoracic duct in any patient, what happened with the lymph? And the answer is it's the lymph finds the way through the different collaterals. I did over 16 years, I did maybe 700 cases, and practically we have almost never had a patient with complication of the thoracic duct occlusion. Interesting, although, that we started to pay attention that all adults with plastic bronchitis, majority of them are by definition obese. There was a recent article from Circulation that demonstrated that all morbidly obese patient has a subtype of heart failure. So I believe right now that whatever we see in adult with plastic bronchitis is very similar to what we see in children with congenital heart disease and plastic bronchitis. So let's move forward for the next pulmonary lymphatic perfusion disease, and it's non-traumatic chylothorax or idiopathic chylothorax. This is our treatment algorithm that works very, very well. The most important part in this algorithm is make sure that their chylothorax is not Chylous Ascities. Why? Because there is a hole in diaphragm, and if a patient, in some patient, if they have Chylous Ascities, and if they have Chylous Ascities and there are holes in diaphragm, negative pressure in the chest can actually pull the fluid into the chest. And this is a OR image which shows you that this is diaphragm and there's a small holes that pull in the lymph into the pleural cavity. Can we treat idiopathic pulmonary perfusion, idiopathic chylothorax? Absolutely, very successfully. In these cases, we can see similar, in some cases we can see a similar pattern to the pulmonary lymphatic perfusion syndrome in plastic bronchitis, where this abnormal flow goes from the thoracic duct toward lung parenchyma. In some patients, we can see that there is not only flow not only coming from the thoracic duct, but from retroperitoneal masses. So obliteration of thoracic duct and the masses cure the problem. This is how we do it. We actually inject glue directly under fluoroscopy guidance into these masses. So this is our recent study that we presented at American Thoracic meeting of the American Thoracic Society, and most of the patients that present with true chylothorax, not Chylous Ascites, we can treat successfully by applying this algorithm. Interestingly enough, even the children with post-traumatic cardiac surgery, most of them, 16 out of 25, have the same pulmonary lymphatic perfusion. So it's an anatomical variant that presents clinically under different conditions. The same with neonatal chylothorax. You can see there's abnormal flow of lymph into the lung parenchyma, and then closing these pathways can cure the patients. Recently, we started to see more and more patients with lymphatic malformation, specifically 3 diagnoses: generalized lymphatic anomaly, Gorham-Stout disease, and Kaposi-form lymphangiomatosis, and of course channel type lymphatic malformation. So how the lymphatic malformation with pulmonary involvement are different than, let's say, channel disorders? They have a systemic involvement. There is usually involvement of the lung, bones, liver, spleen. There's a channel have isolated lymphatic pulmonary lymphatic perfusion most of the time. What are the clinical presentation of this patient? Chylothorax, chylopericardium, chyloptysis, interstitial lung disease, and sometimes plastic bronchitis or mediastinal compression syndromes. So this is a typical interstitial lung disease in patient with Kaposi-form lymphangiomatosis. You can see this is all thickened lymphatic septa in the lung. This is a patient with pleural effusion, chronic pleural effusion that has that been standing from 2010 to 2014 and resulted in significant deterioration of pleural pulmonary function. Chyloptysis is another presentation we treat here at the University of Pennsylvania. This is a pure leakage of a lymph into the lung parenchyma. And what's important is the work by Cameron Trenor demonstrated that all patients with GLA or Kaposi-form lymphangiomatosis survive longer if their lung not involved. So we postulate that if we can discover how the lymphatic system affects the lung and prevent them from happening, we can potentially improve life or prolong life of his patients. And fortunately for us, LGDA, Lymphangiomatosis Government Disease Alliance and Lymphatic Malformation Institute, in collaboration with Pan Orphan Disease, granted us a money grant that we can perform this study. And this is a typical example of the patient with Kaposi-form lymphangiomatosis. First, on the left, this patient has enormous amount of flow in the thoracic duct because probably this disease result in generation of significant amount of lymphatic flow. But this patient doesn't have pulmonary symptoms. On the right, the same patient, the same disease, Kaposi-form lymphangiomatosis, where the patient has significant pulmonary disease, and you can understand why. Because on top of the increased production, there is an overflow of the lymph of the lung parenchyma. This is our index case. Girl presented with interstitial lung disease, and after lung biopsy developed chylothorax. And you can see here there's abnormal pulmonary lymphatic perfusion in the lung on MRI, and if we inject thoracic duct, always flow from a thoracic duct goes into her lung. Can we treat it? Absolutely, we can close it, and we did it, I believe, 2013, 14, and she is asymptomatic since then. What's our diagnostic and treatment protocol of pulmonary lymphatic malformation or anomalies? First, we make sure that the pleural effusion is chylous. Most of the time, it has to have more than 60% of lymphocytes, elevated triglyceride. A lot of patients with Kaposi-form lymphangiomatosis develop DIC. It's a condition where they can easily bleed. And then we perform MR Lymphangogram. So this is a patient I showed earlier that presented with pulmonary symptoms. What can we do here? We can actually get inside the thoracic duct, and this is contrast material inside the thoracic duct, and we can close it. We inject contrast here, but we can close it with coils in glue, and this is MRI immediately after that. You can see all the flow we went into the lung parenchyma right now completely disappeared, and patient 2 days or 3 days after procedure was sent home with no complication. In some patients, we can see again, this is not only thoracic duct, similar to the idiopathic chylothorax, but also retroperitoneal to mediastinal flow here. So you can see it here. What can we do is that we actually can block both thoracic duct and retroperitoneal masses. Another condition we treat quite often is Chylous Ascities. This is an example of traumatic Chylous Ascities. This is a pulling of the contrast that leaks into peritoneum. We can do different procedures for that. One of them, we just inject glue directly into this area and put the coils. This is post-coiling and post-glue injection in this patient. I'm switching completely to complete a different lymphatic system, and this is liver lymphatic system. It's probably one of the most important part of lymph in the body, because again, as I said, liver generates approximately 40 to 50% of the lymphatic flow in the body in normal condition, but can go up to 90% in liver cirrhosis and heart failure. How the lymph is generated? Lymph has very, very specific vascularization. It has artery supplies it and vein. It's called hepatic artery and portal vein. So when blood mixes together from this artery and vein and goes through the structure called sinusoid to drain into hepatic vein, the lymph whips through the wall into the what's called spacer DC and space of Mao. So the lymphatic system, there are two lymphatic systems in the liver: superficial, that goes on the surface, drain the surface of the liver, and deep, that goes along portal vein. This is actually 80-90% of the fluid. Why the lymphatic system is important? Because the moment liver is congested, it immediately generates enormous amount of lymph. And number two, liver lymph is very, very high in proteins. So when we face the problem of protein-losing enteropathy, especially in the patient with heart disease, and protein-losing enteropathy, it's a condition where there is a severe loss of serum proteins into the intestine. We hypothesize that maybe the cause of this protein-losing enteropathy is because of the loss of proteins from the liver into the intestinal wall. And we decided to do procedure what's called liver lymphangiogram. Here we inject dye into the liver, and you can see here there's a leakage of the lymph into the duodenum. And if we inject again, remember, like bronchoscopy, this is endoscopy, and we inject blue dye, we can actually see with our eyes the leakage of the lymph. Can we do something about that? Absolutely. We can embolize, inject glue into these lymphatic ducts, and that's what we do. And here you can see the glue cast on the right and under endoscopy, and this is a glue cast under fluoroscopy. The glue is already opaque, so it looks like a dark spots. So that's how it works. Again, it's a lymphatic variant, anatomical variant, whereas a lymph, instead of going thoracic duct, some of the branches go into the duodenum, and it's okay, it's normal, until the liver started to generate, instead of 800 cc, 3, 4, 5 liters of lymph a day. And at some point, all this lymph overwhelmed this abnormal lymphatic variant, and lymph started to leak out. This is another schematic representation of the same condition. We published it a few months ago, first 8 patients, but by now we have 18. And in this study, in the last 3 patients, we can achieve significant improvement and treat them very, very successfully. And since these 3 patients, most of the patients, we use a new technique that provide us long-term solution. This patient already 1.5 years asymptomatic. We can also some patients present with abnormal lymphatic flow through the liver into the lung parenchyma. We can do exactly the same thing by injecting the glue into these lymphatic ducts. And this is a kid that presented to us with significant lung problems, was actually airlifted from different country, and then after we embolize him, that's his few weeks later, he's doing extraordinarily well and actually went home. This is another example of the same embolization. Recently, we started to see more and more patients with scrotal vulvar edema or leakage, or groin edema. This is how anatomy works in this patient. Usually the lymph from scrotum is drained that way into the inguinal and iliac lymph nodes. In patient with scrotal edema, the flow is opposite. This is a patient with it's not scrotal edema, it's a chylous varices, and when we do MRI lymphangiogram, you can see beautifully the lymphatic ducts perfusing the scrotum. This is a girl that presented with a vulvar leakage for 5-6 years. When we do an MRI lymphangiogram and inject contrast here, you can see that all the contrast go actually in the vulval area, and by injecting glue into lymph node that supplies this area, we can treat this condition very, very well. We have 4 patients right now treated successfully, and we believe that most of the scrotal edema, it's not obstruction, it's more reversed of the flow of the lymphatic system from the leg or from the abdomen into the inguinal area, and the embolization. These pathways can reduce the symptoms. This is the same patient. You can see the MRI of the same patient. You can see here, this is a pathway to the scrotum. This is the inguinal area. So what's the future? Future is tremendous for lymphatic imaging intervention. We actually can treat very, very successfully chronic interstitial lung disease in some patients, bronchopulmonary dysplasia, chronic bronchitis, by embolizing the lymphatic pathway. We very, very close work, extensive work with liver lymphatic embolization by treating protein-losing enteropathy, but also looking into the cardiac ascites, liver cirrhosis ascites. We started to sample fluid from the thoracic duct, and we already discovered that pathophysiology lymphatic system is different than we thought before. We starting the study where we try to divert the lymph in patient with intensive care patients, because there's a strong feeling, a strong knowledge about the fact that the lymph in ICU patients that originates from the gut can cause this tremendous multi-system organ failure, and by diverting the lymph, we can prevent this multi-organ failure. We potentially can treat congestive heart disease because congestion is a lymphatic congestion, even in heart disease. Some types of immunotherapy, CAR T-cell depletion therapy. The key for everything is developing a new lymphatic imaging agents. We're working right now with chemists trying to develop for us intestinal lymphatic imaging, liver lymphatic imaging, and very hopefully pretty soon we'll have this agent and we can image the whole lymphatic system, and then we can discover more diseases. So thank you very much, and I just open the forum for the questions. This is our contact information. We have a Center for Lymphatic Imaging and Intervention at the University of Pennsylvania and Children's Hospital. Please, if you have any questions, I will be happy to answer in email, or we accept patients from all the country, from different countries, and please do. Thank you very much. So, question from Laura. What type of radiology imaging is helpful before a visit? We chest CT and MRI of the abdomen and pelvis. So how we perform the MR lymphangiogram? Usually when people come into us, usually if they come on Monday, we see you in the clinic. In the same day we do MR lymphangiogram. It's performed in the special unit where with MRI has detachable table. The patient will come. We will detach the table, put it in a holding area or ultrasound room, Then we will put this tiny needle into lymph nodes and then the slide patient inside the MRI where we can inject contrast. The contrast, the question is, what if I'm allergic to contrast dye? The contrast we inject is gadolinium-based contrast. There's almost no allergy to that. However, if somebody has allergy, we can do special prep to combat this condition. Question from Colleen: what are some common risks and some side effect embolization? Generally, it's a very, very safe procedure, but most of the time, there's two potential complications that could happen: is infection because we access through the abdominal wall, or bleeding. For adult patients, we extraordinarily rare see those. Question from JC: how is a traditional lymphangiogram different from the MR lymphangiogram? So truly the major difference between intranodal lymphangiogram or PLE lymphangiogram and the MR lymphangiogram is there are two. Number one, the contrast that we're using. For traditional lymphangiogram, we use the very, very heavy and thick oil, and this oil barely track through the lymphatic pathways, where for MRI we use gadolinium-based water that contrast that similar to water in its viscosity, so it goes much quicker. Number one. Number two, with MRI there's very, very, very high signal to noise ratio, so we actually can see our contrast much better, but also we can see the much better surrounding tissues in three-dimensional. Question from Judy: is there any way to obtain literature regarding all of this information? We publish multiple articles. Please email me. I will be happy to email you back the articles. We have multiple reviews articles, so there's. But if you have very, very specific question, please email us and ask us, and we'll be happy to help you. There is a question from Jo: interstitial lung disease. Could this show up as emphysema on elderly non-smoker years ago, since this wasn't available but had lipedema? Most of the time, interstitial lung disease in lymphatic system does not present as emphysema. I think there's all questions. Thank you very much for your attention. Please don't hesitate to contact us if you have any questions. Thank you very much.